We have talked a lot about heart failure with reduced ejection fraction less than 40%. We have great drugs, we have the ARNIs, we have the SGLT2 inhibitors, we have the MRAs, beta blockers. But there is a gray area in the heart failure therapy, that is the heart failure with preserved ejection fraction. Apart from the drugs like SGLT2 inhibitors, the empagliflozin in the Emperor preserved trial and the dapagliflozin in the Deliver trial, none of the drugs so far has shown in trials to be beneficial in the heart failure with preserved ejection fraction for reduction of the cardiovascular deaths and heart failure hospitalization. In fact, the ARNI has undergone a trial, which is the Paragon heart failure trial, wherein ARNI was compared with the valsartan group in the heart failure with preserved ejection fraction patients, and this trial was a disappointment. This trial did not show significant reduction in the cardiovascular death and heart failure hospitalization in the ARNI group as compared to the valsartan group. In fact, the result just missed the statistical significance narrowly. But if we go into the deeper details of this trial and we do a subgroup analysis according to the ejection fraction, then the ejection fraction between the 40 to 50 group and the 50 to 55 group probably showed a significant benefit in the sacubitril valsartan arm as compared to the valsartan arm, and therefore we can extend the observation and conclude that maybe in the mid-range ejection fraction between 40 to 45 ejection fraction group, probably the ARNI has benefit as compared to valsartan, and this has led to a change in the guidelines. The guidelines, the American College of Cardiology guidelines, the latest ones in 2022 are now saying that apart from the heart failure with reduced ejection fraction, even for the mid-range ejection fraction and the preserved ejection fraction, or mildly reduced ejection fraction and the preserved ejection fraction, you may extend the heart failure therapy, you may extend the 4 pillars of heart failure, that is the SGLT2 inhibitors, the ARNI, the beta blockers and MRA, even to the patients with mid-range or mildly reduced ejection fraction between 40 to 45 and more than 50. So the now guidelines stand that all heart failure patients with lower than normal ejection fraction can be started the 4 pillars of therapy, and therefore ARNI can be given to patients who are having ejection fraction between 40 to 55 or a slightly reduced ejection fraction. But the ACC also includes one line which says that ejection fraction is a subjective evaluation. The ejection fraction, the same ejection fraction may be reported differently by 2 different observers, and therefore the ejection fraction should not be the sole guide to the treatment of the heart failure patient. All heart failure patients should be extended the benefit of the heart failure 4 pillars of heart failure therapy, including ARNI.